Hi, my name is Dr. Stephen Nathan. I'm the Medical Director of the Advanced Lung Disease and Lung Transplant Program at Inova Fairfax Hospital, which is in Falls Church, Virginia. Today I'm going to be talking to you about a lung condition called sarcoidosis that can be complicated by the development of pulmonary hypertension. There is an intersection between lung disease and pulmonary hypertension. If you look at the WHO classification of pulmonary hypertension, we have groups 1, 2, 3, 4, 5. The two where we have drugs approved are Group 1 PAH and Group 4 CTEPH. Group 2 is pulmonary hypertension due to heart disease. Group 3 is pulmonary hypertension due to lung disease, where we have no PH drugs proven to be effective, therefore no drugs approved in this area of pulmonary hypertension. And then in Group 5, we have various miscellaneous conditions. Sarcoidosis is a condition that we see fairly frequently in our program. It is primarily a lung disease. It's a disease characterized by what we term non-caseating granulomas. These non-caseating granulomas can occur anywhere within the body. So it's a systemic disease, but the most common locale for these non-caseating granulomas is in the lungs. Now, it is a disease that's slightly more prevalent in African Americans, also certain pockets in Europe, like in Ireland and in the Scandinavian countries, I believe, there's a higher prevalence of sarcoidosis. It is a disease that is somewhat unpredictable in that it is prone to spontaneous resolution in many cases. The lungs tend to invariably be involved in upwards of, I'd say, about 90% of cases, even if patients are asymptomatic. Frequently, if you do a lung biopsy, you'll see these non-caseating granulomas. So they can just be sitting there without having any pathophysiologic consequence. However, in some patients, they will develop lung disease. There are various stages of lung disease. We talk about skating stage 1 through 4, with stage 4 being less common, fortunately, because those are the patients who go on to develop progressive fibrocavitary lung disease, and estimated about 20% of patients who have pulmonary sarcoidosis will go on to stage 4 fibrocystic lung disease. Now, pulmonary hypertension can complicate any form of diffuse parenchymal lung disease, including sarcoidosis, and sarcoidosis tends to have a higher prevalence of pulmonary hypertension than some of the other lung conditions that we deal with. For example, idiopathic pulmonary fibrosis, COPD. The prevalence of PH tends to be high in sarcoidosis because it appears that it's more than the lung disease itself and the destructive changes happening in the lung parenchyma. The non-caseating granulomas that characterize sarcoidosis can affect the pulmonary vasculature primarily, giving essentially a pulmonary vasculitis, which can lead to pulmonary hypertension, albeit this is a rare cause of pulmonary hypertension in the context of sarcoidosis. Sarcoidosis is also unique because one of the characteristic features is that you can get hilar and mediastinal lymphadenopathy. That means the lymph nodes in the mid-chest region can enlarge. That's fairly characteristic for sarcoidosis. And in some cases, these can go on to develop fibrosis, can have essentially a fibrosing mediastinitis, which is just fibrosis of the mediastinum, which is the central part of the thoracic anatomical structures. The downstream consequences of this is that these can involve the vessels and it can cause mechanical obstruction of the pulmonary vessels, leading to pulmonary hypertension. So sarcoid can result in pulmonary hypertension, which may be multifactorial. The main reason is the parenchymal lung disease and the lung destruction that occurs, but also the changes in the mediastinum, the granulomatous vasculitis that I mentioned as well, can all lead to pulmonary hypertension. And for this reason, even though it's primarily a lung disease, sarcoidosis is categorized in Group 5 in terms of the World Health Organization classification of pulmonary hypertension. If you look at patients with advanced pulmonary sarcoidosis, for example, patients who have progressive disease requiring transplantation, about 70 to 80% of these patients will have complicating pulmonary hypertension. We know that pulmonary hypertension complicating any lung disease portends a worse outcome, including sarcoidosis. It's been shown in numerous studies that those patients who have complicating pulmonary hypertension have significantly worse functional status as well as a higher propensity for mortalities. Therefore, it does portend a poorer prognosis. The big question and the looming question out there for which we don't have an answer is, even though we know that pulmonary hypertension associated with lung disease, including sarcoidosis, is associated with worse outcomes, and even though we have multiple medications that can treat pulmonary hypertension. What we don't know is whether treating the pulmonary hypertension of sarcoidosis or any other lung disease for that matter will result in improved outcomes. There have been a number of studies, mostly small series, retrospective reviews that have looked at this issue, and the data specifically in sarcoid is a little bit conflicting. There are some ongoing studies in sarcoidosis looking at treating the pH of sarcoidosis as a way of improving patient outcomes, but we don't have any definitive data as yet. Most patients will present with sarcoid first, with pulmonary hypertension being discovered down the road once they have a well-established sarcoidosis, and usually in the context of stage 4 sarcoidosis, although it can occur in stage 2 and 3 as well. When to be suspicious that a patient with sarcoidosis might be developing pulmonary hypertension is a good question that is probably multifactorial in its answer. In other words, there are many different things that might clue one in to the presence of complicating pulmonary hypertension. For example, if a patient has dyspnea that's out of proportion to the lung parenchymal abnormalities or out of proportion to what the PFTs look like, if the patient is requiring oxygen, has significant desaturation, has a limited 6-minute walk test. These are all clues to the presence of pulmonary hypertension. Another clue might be to look at the CT itself and look at the size of the pulmonary artery. And if the pulmonary artery to aorta ratio is greater than 1, then this might suggest underlying pulmonary hypertension. The best screening tool for pulmonary hypertension in any case is echocardiogram, and the echo might show evidence of pulmonary hypertension. It might show evidence of right ventricular dysfunction. It's an important point to make that echo is not the diagnostic gold standard. Of course, the diagnostic gold standard remains right heart catheterization in sarcoidosis patients as it is in patients with group 1 PAH. What I would like to leave the listeners with is if you have a patient with sarcoidosis, there are expert centers around the country, and especially if you suspect that they are developing pulmonary hypertension, then they probably warrant referral to a pulmonary hypertension comprehensive care center for further evaluation and discussion with regards to treatment options. My name is Dr. Stephen Nathan, and I'm certainly aware that I am quite rare.